pleasure to actually introduce someone who needs no introduction. And Pat Lawson-Muse, we're so pleased to have you with us today. Pat anchors News 4 at 4 with Jim Hanley and hosts the Reporter's Notebook, a weekly public affairs shown Sunday mornings. She also files reports for News 4 afternoon and evening newscasts and is a host for News 4 This Week, a weekly show highlighting stories from the Washington, D.C. area. And Pat, would you join us? And we thank you for coming. I understand those long introductions.
Thank you, Jackie, and good morning. Good morning. I was so praying she wouldn't continue that bio, the long version. Good morning. It's a pleasure to be with you. It's also a little bit exciting for me to be with you because we're covering this story as news. And so it's part of our daily appetite, as well as your daily appetite. But it's very interesting to be in the room with the policymakers and the partners and those of you who are responsible for making implementation of the Affordable Care Act here in the nation's capital work. We all know the health insurance marketplace is up and running, and now that it's become law, there's lots to learn on the part of the media, as well as those who are participating and who are recipients of the new health care reform. So I'd like to bring our panel up. Since they're still in their chairs, they need to come up to our to the podium. And I can introduce you if you like. Karen Dale, come down. Linda Elam, Mila Kaufman, Maria Harris-Tilden, Louis Padilla, Fahad Tahir, and Eric Wagner. If you please take your places, and let's welcome them as they join us this morning. So I think the Jackie Bowens has sort of put the challenge out there. She stated that your goal is partnership, collaboration, networking, and engagement, and that is what these two panels are about today. This first panel of guests are people who are serious stakeholders, as you all are, and I'd like to introduce each one and ask each one to make their opening statements, and then we'll begin with questions from all of us. Karen Dale is an RN, Executive Director of AmeriHealth, District of Columbia, managed care organization serving thousands of D.C. residents that receive Medicaid. Linda Elam is PhD, Deputy Director and State Medicaid Director of the D.C. Department of Healthcare Finance. Dr. Elam has oversight over our local Medicaid program on behalf of the D.C. government. Mila Kaufman is Executive Director of D.C. Health Benefits, the Exchange Authority, which we all know is a new entity here in the nation's capital. She heads up the recently launched insurance exchange for the district that we know, launched on October 1st. Maria Harris-Tilden, Senior Vice President of Public Policy and Community Affairs at CareFirst Blue Cross Blue Shield. She represents a commercial insurance provider supporting many of our health initiatives and is a provider in the New Health Exchange. Louis Padilla with Maryland Unity Healthcare, Inc., representing the largest federally qualified health center here in the district, serving patients in more than 28 locations. Fahad Tahir, Vice President, Physician Enterprise at Providence Hospital, and Eric Wagner, Executive Vice President of External Affairs and Diversified Operations at MedStar. Let's welcome them again. Karen Dale will begin with your opening remarks, and you each have, they said 5 minutes. We'll make it 4 so you have a minute to be wrapped up, and I understand there's a timekeeper here, and it's not me. Karen Dale.
Thank you. Good morning. As a leader in managed care, and I hope you all like my new voice I'm trying out here this morning, AmeriHealth Caritas for 30 years has served nearly 5 million persons. We serve over 100,000 members in the district. So we couldn't be more pleased with the Affordable Care Act and the opportunity that it provides. In my 4 minutes, I'll talk about opportunities, new approaches, and challenges. In terms of opportunities, the Affordable Care Act really gives us a season to address health inequities. And I know this is something that's very close to the heart of many of us who've been in this struggle to change some of the health outcomes that we see here in the district. We've seen improvement. We've had lots of pilots and initiatives. However, we have to move from pilots and initiatives and things that get unfunded at the end of a grant cycle to really having things that are sustainable and create change for the long term. In terms of health inequities, the Affordable Care Act allows for us to have more interventions that can be tested and really put through the rigor of research. We need to understand very clearly what are those differences that cause the health outcomes in Wards 7 and 8 to be so markedly different from other parts of the district. We think we know. I'm not sure that we've had enough research to answer those questions. And so we can test approaches, we can look at comparative effectiveness, we can do more predictive analytics, and those are things that need to really be the underpinning, the evidence-based component of the work that we do. And I believe very strongly that if we are able to put that type of effort, we can address more clearly the issues around health disparities. We also have to look at some of the access issues and cultural competency, and again, the Affordable Act gives funding to do that. We need to understand what are the differences for certain subpopulations that live in our community in terms of their culture and how they view health through through the context of their culture. And so I see those things as the opportunities. In terms of the new approaches, we have done a number of things, again, in terms of pilots and initiatives that we now need to take to scale. Things such as sharing clinically relevant information. Unity has been a great partner with AmeriHealth and previously chartered in sharing information. So we've provided to them those members on their panel that have high emergency room visits, those members on their panel that have high ambulance utilization. As a managed care organization, we pay claims and have all this information, but it's not useful to sit just with us. That information is best put in the hands of clinicians in order to have a different conversation when they see a member. So we share clinically relevant information, we partner so we leverage what the stakeholders do best. We have gone beyond our partnerships with federally qualified health centers and are now partnering with many community organizations that have best practices. In terms of the challenges, I would say that change is our biggest challenge. Fahad and I were on a panel earlier last week, and one of the things that the moderator stated was, isn't someone going to not make as much money as they did before? And he wouldn't let it go, right? He said, if hospitals don't have their emergency rooms full, isn't that going to be a problem? And I said, yes and no. In some ways, what we have to do is to let go of those things that we've held so closely to and be truly open to working together to change our health system, to transform it in such a way that when we speak to a member, the member says, I'm not confused about where I need to go. I'm not confused because 3 different people called me about the same thing. We want the members to have a markedly different experience, and that will be, along with research, the test of whether we've made the changes.
Linda Elam.
Good morning, everyone.
Good morning.
Well, I love to be able to tell people, and I get to tell a lot of people, actually. I call myself the Medicaid cheap date. Being the Medicaid director here in D.C., where we have a lot of conferences, busy times like this, folks can't travel, things happen. They're like, oh yeah, call Linda. She'll come down here quickly, and we don't have to fly her in, put her up, or anything. But I love it because, by now they know, but they didn't used to know how great DC is and the kinds of advances that we've made, and it gives me a chance to tell our story. And one of the things that I love to tell people is that we've been a leader in implementing the Affordable Care Act since 2010. We expanded Medicaid, second behind Connecticut, just a couple of weeks behind Connecticut. We've been blazing that trail since the law became law. We have done so much in the district to expand coverage to people, provide a robust package of benefits to people. And we will continue to do what we can to get those last few people enrolled. But what I would like to just put out there for discussion is that no matter how well we all do our jobs, and I'm a true believer in coverage, I've worked in insurance, Medicaid for a long time, and access. But for those of us in the room, we are still working in about 15% of the pie when it comes to what makes people healthy. And so, as innovators, as trailblazers, as thought leaders, as I like to say we are in the district, it's time for us to start thinking about where that ball goes. The biggest impact on health for the populations that I'm working with is poverty. And Medicaid won't solve poverty. Hospitals won't solve poverty, and I understand that. But I think the charge to us is to be creative about how we marshal the wonderful resources we have, the advantages we have, to really reach out to the populations that we serve. On the government side, I think our responsibility primarily, besides being a good Medicaid program, is to get the right people around the table to start talking about what's the next step, what's our next evolution. And yeah, there will be people that will lose in their current incarnation. What we have to do is help prod them along to the next incarnation so that they're able to continue to do good work and make a living and have a sustainable program. So we will continue to move forward. We're very excited about the Affordable Care Act and being a leader. And again, we have to move past just the coverage and just the access and look at what we can do to really impact people's lives in the schools, in their communities, look at jobs creation, all those things, housing, it all adds up to health. So.
Thank you so much. Mila Kaufman.
I love to preempt Care First. Thank you so much. First of all, where's the breathologist? Where are you? I love you. I fell asleep. It was the best few minutes the last 9 months I've ever had, I have to say. Thank you. Thank you, Jackie, for your leadership. It's been a pleasure getting to know you over the last several months, and it's great to have you as my partner in all of this. So thank you to your staff. Thank you to you. And where's Eric, by the way? I'm going to embarrass people here. Where's Eric? He's hiding. Okay. Well, he's been with us following all of our policy discussions, all our work groups since day one. I think he was the first person I met from your team. So thank you. Thank you to a great team. I also want to acknowledge some of your board members who not only have been with us from day one, but had crazy moments and volunteered to chair some of our policy work groups. Thank you to Dawn, and thank you to Unity, who participated in a bunch of them. So thank you very much. I would not be here today excited about going live October 1 if it wasn't for all of you who helped me and my team get here. So thank you. So October 1, and I'll follow Dr. Garcia's advice because a doctor is always right. I will tell you what happened October 1. Bloomberg News was reporting that we were one of four states in the nation to go live. We opened up. We worked all day. We didn't crash. And not only that, but people were actually able to go from start to finish. They opened up their accounts. They shopped for health plans, and they actually hit pay buttons. So, which is amazing. We also have, I would say, the best shop, the best small business marketplace in the nation. As you can tell, I'm not really shy, right? We do, and several weeks ago we found out that all of Congress is going to be our client, essentially. So we're going to get all of the senators, all of the representatives, and the 9,000 congressional staff. So, thank you, Care First, for sticking around as one of my partners after you learned about that. No, but in all seriousness, the reason why we are so competitive and so successful is because we have great partnerships, and we're able to offer the types of choices that other state marketplaces cannot. We have all of the major insurance companies who have been committed to helping this work. They're offering a bunch of different products. For the small business side, we have 267 different products, everything from HSAs to very low deductibles. On the individual side, we have 34 different products, everything from no deductibles to higher deductibles. So, here, insurance companies are not limiting their networks. It's the same networks that they offer currently in today's market. So, unlike other states, our insurance partners here, our insurance companies here are great partners, and they recognize the necessity, the need to succeed in all of this. They recognize that everyone must get coverage. I know I'm out of time, but I just wanted to share some numbers with you which are not yet public. So you're the first to hear. As of 8 a.m. This Monday, we had thank you for taking notes, 8,239 accounts that were opened on the individual side. 234 employer accounts were opened through our web portal, dchealthlink.com is the address, dchealthlink.com. We had over 1,000 individual applications completed online. I don't have the paper counts yet, but we're getting them soon. So over 1,000 individual applications. Half of those were requesting either Medicaid or premium reductions. The other half were not. And there were 6,176 users who were shopping for coverage. So they were using our plan shopping option. 159 individuals actually made their plan selection. They figured out which health plan is right for them. 84 hit pay button, which shocked me, quite honestly. I didn't think anyone would be paying this early for something that doesn't become effective until January 1, and that they have until December 15th to pay for. But nonetheless, thank you to the 84. I don't know if any of you are here, but thank you. And also, one of the things we've learned, and I got my staff together yesterday to look back at week 1 to see what did we do well, what do we need to do better. And one of the conclusions was that there's absolutely pent-up demand here. We were surprised that in all of our outreach sessions, and we've done a bunch in libraries and other areas, it's not only a show and tell, here's how the web portal works, but people are showing up to enroll, which really surprised me. There's a huge, huge demand for affordable coverage, and now people have a real opportunity to find a health plan that fits their needs and their budget. So I just want to conclude by saying this has never been a job for me. In fact, I would have said no if it was just a job. It really is a passion and it's a calling for my entire team and myself. When I was superintendent of insurance in Maine, I went all over the state and did hearings on rate increases. And I met lots of people, and I'll just share one story with you, and this is what keeps me going. I know I'm out of time, but I just want to share this story with you. So I met a young woman in her 20s whose baby was sick. She called an ambulance, and the ambulance came and asked if she had health insurance. She said no. So the ambulance took her baby, but would not allow her to ride in the ambulance with the baby. On the way to the hospital, unfortunately, the baby passed away. And so that's the face of the uninsured today. And we know because of the Affordable Care Act, we will never see that face again, right? And with all of you as our partners, we'll make sure that every single baby, every single mom, every single dad, every single individual who lives and works here in the district has good coverage. So thank you very much, and thank you for the extra few minutes.
Maria Harris Tilden.
Well, thank you and good morning, and what a pleasure it is to have an opportunity to sit next to my partner here. We've been spending an awful lot of time together, and I'm proud to say that it really is a full partnership. As you know, I'm with Care First Blue Cross Blue Shield, and some of you may ask, well, what are you doing here? Why are you here? You don't participate in the Medicaid market. You're not an MCO. But it's important for many folks to appreciate that Care First is actually a not-for-profit organization. And in addition to providing good service and good products to our members, it is our community mission, and we take it very seriously, to look for every opportunity to reinvest and expand access to quality health care in our community. I'm proud to say that I feel like I am a full partner in this room. There are many, many familiar faces in the audience. I'm looking at my buddies in the front row. We have for many, many years had very deep and productive relationships with the Primary Care Association and your members. Again, our goal is to identify opportunities to catalyze not only access to care, but efficiencies in the healthcare delivery system. And it's important to appreciate that ACA is relevant to us in the context of your organization. As Mila noted, in addition to offering, we're obviously offering a number of products in both the individual and shop exchanges, but as a consequence of the premium subsidies, many of your new members will actually be our members. And so we want to do everything that we possibly can to ensure that we play a role in assisting each and every one of the organizations in this room to be ready for what we know will be additional patients, and to do everything that we possibly can to ensure that you are 150% ready for this expanded patient population, doing things like what Unity is, and we've invested in it through our primary patient-centered medical home program. We're actually working on an ER diversion program with Unity. We're allowing them or helping to allow them to expand access, adding more hours, adding more days, weekend capacity to see patients, because we do appreciate that each and every one of you, now that you have more folks that have coverage and will have coverage, we'll need to identify how you can best serve them. So again, it's our pleasure to continue the partnership with your organizations. We look forward to being at the table to tackle those challenges that you will face as you look at more membership and as you try to identify ways to not only improve quality, but to really tackle costs. We look forward to, as we have through our patient-centered medical home program, which we actually introduced to our commercial members, where we found a way through an initiative we launched 3 years ago to actually extend that program, which again looks to better navigating, better coordinating care of multiple chronic condition members, allowing the safety net community the opportunity to also get the benefits from those learnings. So again, we appreciate the opportunity to be at the table. We look forward to continuing our long-standing relationship with your programs. And Jackie, congratulations on leading such an important organization to the people of the District of Columbia.
Now that we've heard from all of the women, we'll get to the men. And I just want you to know that this seating arrangement, I don't think was intentional.
I think it was.
Luis Padilla.
Thank you. Definitely the important voices were heard first. Thank you very much. And it's a pleasure to be here, and thank you very much I'm humbled by the leadership that I'm here with, that's talking about a very important and timely issue. So I'd just like to get started with some of the key elements that the ACA has presented us with. All of us know about Medicaid expansion, the insurance exchange creation, teaching health centers, accountable care organizations, the individual insurance mandate. All these things are critical to improving our healthcare system, and we all know that. The insurance exchange's promises through cost sharing, subsidies, health benefit packages, affordable quality health care by 2014 for the majority of Americans who don't otherwise have insurance, and that is wonderful. And we've been hearing over and over again, access, access. But I posit to you, access to what? Access to a healthcare system that traditionally has been volume-based, that has been specialty-driven, that has relied on outcomes that are process measures, that has been disintegrated, uncoordinated, and fragmented population care. And really, as many of us already heard, have not really tackled, as Linda said, the social, and Mr. Jones have mentioned, the social determinants of health, those upstream measures that are affecting our communities day in and day out. So as we look at access and access to that current system, the challenge for us is how do we transition to a value-based system of care, one that is integrated, coordinated, puts patient-centered outcomes at the center of what we do. Meaningful measures become meaningless when they're not patient-centered and patient-driven. So, with that, we have many opportunities here. We have opportunities to integrate and organize into practice units that are not simply patient-centered medical homes, but geared towards the chronic conditions that we see in our population. We have opportunities now to participate in a citywide functional health information exchange, of which we cannot do the things that we want to do. We have an opportunity to advocate for real payment reform that bundles payments for those results that we want to see in our healthcare system, not for volume. We have an opportunity to collect data that's really patient-driven and presented to teams to modify the care that they deliver. And we have an opportunity, as has been mentioned by Ms. Bowens, to build upon the partnerships that we've created, the real partnerships that we've created, and expand them, and come together in this marketplace that has a tendency to create divisiveness among collaborators. And also to continue to leverage the social determinants of health. This cannot be understated. As Mr. Jones eloquently pointed out, and another one of my colleagues written a book, Rishi Manchada, Upstream Doctors, this is clear to us. 30 to 40% of the disparities that we see are driven by where we work, where we learn, where we play, and where we eat. We need to begin to address those. So I leave you with this rather deceptively simple formula. Value equals quality over cost. This is deceptively simple because these things are incredibly difficult to implement. But as been mentioned here, if we work together, put aside some of our differences, and begin to tackle this, we can be seen as a premier healthcare system in the nation. Thank you.
Dr. Fahad Tahir.
So, good morning, everyone. As you know, Providence has long been in the neighborhood like Jackie's family. We've been here, though, for 150 years. And so we really know our community. but we really know our community. We really know, I think, and have really started to develop deep roots in different aspects of the healthcare system. Providence has a hospital, a nursing home, and a physician organization of 250-plus providers. And I'm proud to mention that we just found out last week one of our primary care clinics just became a patient-centered medical home certified just last week, and with the support of DCPCA. And they're here and they're cheering. I would not be able to get to the panel without mentioning it. So really, when we look at both through our relationship with Ascension Health, which has hospitals and systems throughout the country, as well as our history here in DC, we really see what the federal government has done in the context of the approach of the Affordable Care Act is really address three big components of what we were facing at that time. Gross domestic product, 17% of the GDP in this country was spent on health care, projected to go to 20% by 2020, and 6% in 1965. So when you step back and look at it, the economic drivers were significant. Number two, the state Medicaid plans were just really struggling, and the Medicaid budgets were the biggest drivers throughout the country in several states. And then the continued transfer of healthcare costs to employers and consumers, that started to approach not just a issue for the poor, but rather also an issue for the middle class. And some of the just amazing statistics I've learned in this journey to re-understanding the perspective of Congress as Affordable Care Act developed. In 2002, 15% of the median family income was devoted to health care. And in 2011, that had jumped to 26%. And so when the economic burden starts to shift from the poor and the vulnerable, who Providence has long been committed to and those in this room have long been committed to start impacting the middle class, it starts to get the attention of Congress in a different way. And that was the environment in which the Affordable Care Act came forward. So the Affordable Care Act, in a lot of ways, had a variety of challenges, but is ultimately a healthcare financing strategy rather than a healthcare delivery strategy. And so I think it's our job in this room to develop the delivery side of this conversation. And so as we step back and look at what does the new healthcare financing policy really need from its delivery arm, which is those of us in this room, number one, a fundamental reconfiguration of how we deliver healthcare. We can no longer be in isolated buckets and silos, not communicating, not interacting, not exchanging information. Number two, there have to be a different level of clinical integration between the different players that take care of patients. And number three, we have to learn to share risk and reward with our payer partners in a different way. We know that we can't own everything that our patients touch, for example. We care for 50,000 community members through the Providence system, but we can't own every clinic, we can't employ every doctor, we can't be the payer for every patient. So we have to really step back and think of ourselves differently as a member of a clinically integrated team, and we don't own every element of that team, but we have to work in equal and fair partnership with those of us in this room that we share patients with. And so a traditional hospital has started to evolve into a hospital system, which is now, better said, started to evolve into a health system, which, better said, starts to evolve into a system of care where we're a member of a larger contiguous process of care. And then what I've learned from the patient-centered medical home journey is ultimately this health system exists because it's a patient-centered medical home without walls. What doctors couldn't do 20 years ago as solo practitioners in primary care evolved into the patient-centered medical home and the team concept of care, because we can do it better in care teams. As Dr. Padilla said, when we step back and look at the purpose of our health system, it's ultimately to provide more infrastructure and support and resources around that patient-centered medical home and really create a very organized and predictable way patients move through the system. So we're looking forward to engaging with our partners in this dialogue.
And Mr. Eric Wagner.
Very good, and I must be down to about 30 seconds now, but
You get your 5.
thank you very much. And I appreciate the opportunity to be here and appreciate hearing from all of my colleagues up here on the dais. I want to start with a little bit about MedStar Health, because I think some of you know some pieces of us, some of you know other pieces of us, but it might be helpful in terms of the full context. So like many of you in the room, MedStar Health is a charitable, community-based, not-for-profit organization. We're not a shareholder company. We don't have investors. We are just like you, except on a much larger scale. We're an integrated healthcare system today with more than 20 health-related organizations, 10 hospitals, 3 of which are here in the District of Columbia. We have 30,000 associates who work for us across the region, many of whom live here in the District of Columbia. 7,000 nurses. So when you think about nursing issues within your own organization and recruitment challenges, multiply it by 7,000. 5,600 affiliated physicians across the system, 1,400 of whom are employed by MedStar, and over 700 employed physicians here in the District of Columbia predominantly at the Washington Hospital Center or MedStar Georgetown University Hospital. Intrigued by the comment on patient-centered medical home, more than 17 of our primary care offices have been certified by NCQA as patient-centered medical homes. They participate with Care First program. So a lot on the provider side,
but also a piece on the payer side. MedStar Family Choice is our Medicaid HMO. We've been operating in Maryland for the last 17 years, and our focus, and I think what has made us successful, is putting the patient first. We're focused on what the patient needs and on quality, and in our view, all else follows from that. And we're proud to be among the top 20 Medicaid HMOs nationally in terms of our quality metrics. And today we have 70,000 enrollees spread between Maryland and the District of Columbia. Again, just a couple other statistics to put it all in context. 150,000 annual admissions to our hospitals. That's more than 410 patients every day being admitted to a MedStar hospital. We provide care for 1 out of 5 Maryland and District of Columbia residents every year. We see 3.7 million, more than 3.7 million outpatient visits each year. Our top line revenue, $4.2 billion. Okay, sounds like a huge number. Our margins are less than 2%. That all translates down to less than $80 million in annual operating income. And from that $80 million, we need to make the reinvestments that we need in our facilities, our equipment, and serving our patients. We provided last year $311 million in community benefits across the region. Over $200 million of that was provided by our district-based hospitals. We provide care for a third of the safety net population, or those covered by the safety net programs in the District of Columbia. So we are a part of the community. Our care is part of the community, and we're here to stay. I think as we were reflecting, or as I was reflecting on, well, this will be good if I can make it work. No, I'm not going to make it work.
It's working.
Oh, okay, it is now working. Great. Reflecting on, what does the Affordable Care Act mean for us? We actually started thinking about how do we transform our health system several years before the Affordable Care Act became law. When our current CEO took office 5.5 years ago, Ken Samet, he put together a group to flesh out his idea of a distributed care delivery network. And the chart really shows the pieces that folks focused on. And a lot of things on the left side which get to how do we relate to consumers and patients, and then the trouble ahead and a focus on value. And that's what our journey has been about. And if I had just 30 more seconds, what I would circle is there on both sides the word partnership. And the word partnership has come up several times today. This is not about MedStar trying to do everything by itself. It's about MedStar working with physicians in the community and other community practitioners. And I'm proud to say that of my fellow panelists, we're partners with many up here, with Linda in terms of our program in the district, with Maria in terms of Care First, both as our health insurer and as a provider for their networks and a PCMH provider. Not on the exchange yet, but hope to be. With Lewis at Unity in terms of clinical programs, and even with Providence Hospital, which competes with us on the acute care side, but for 17 years we've operated the police and fire clinic to serve first responders here in the district. We've done it well, and it's brought the best of both organizations together. So let me close there and just say I'm very excited to be here today and happy to work with you all. Many friends in the audience. Thank you very much.
Thanks to all of you. A question for Ms. Kaufman. In your leadership role, what do you see as the top 3 issues that will directly influence the way the benefits exchange will operate in this new marketplace? And can you address the issue of partnership, collaboration, competition, and value?
Okay, so I'll just say, biggest issue for me personally is lack of sleep, but I know that's not the question. So let me just start by saying IT has always been a big challenge. What each of the state marketplaces have been asked to do has never been done in this nation. Actually, it's never been done in the world. We're asked in a very real time, very quick, less than a second, be able to figure out if someone is eligible for Medicaid or eligible for premium reductions. And in a few minutes, we're asked to, from start to finish, get the person enrolled after he or she chooses a health plan. And we're asked to make sure that the person qualifies, doesn't have job-based coverage, qualifies meaning is a district resident, is documented. So we're asked to connect to the IRS and Homeland Security and local data hubs, and that will continue to be a challenge as we move forward. Now, luckily, we were able to build our core functions in DC HealthLink very well. We've tested it with all of our partners, and we know the core functions work. But moving from now until the end of this year and then most of next year, we plan to add lots of new tools so consumers could have an easier shopping experience. And all of those will have probably some kinks. You have to anticipate that. And we'll always try to improve. You know, when I was reminded of recently when Apple first launched their phones, there was a lot of excitement, and then probably twice a year they kept offering new options and improvements. So that's the way I view us in terms of the technology piece. On the coverage piece, the challenge for us all, for our insurance insurance company partners, for the physicians, the other medical providers, the challenge is once we get everyone covered, and I fully anticipate we will get everyone covered here in the district because we have many committed partners and people are dedicated to getting everyone that insurance card. Once we do that, all of us must be at the table, right? Because the next challenge is how do we make sure that people's health improves? How do we make sure that people have access to physicians where they live? How do we make sure that they get the necessary care and appropriate care and not too many tests? So all of that is really going to be the significant challenge that all of us have to be at the table for and meet. Because without that, we haven't achieved much, right?
Thank you very much. I'd like to ask Karen Dale and Dr. Padilla to respond to Ms. Tilden's concerns about how are you going to handle all these new people who are coming into the system, and tell us why patients should choose one over the other, and how you avoid the fight that comes from competition. Or how are you going to deal with it since you can't avoid it? Dr. Padilla?
Okay.
It's like, who's on first?
So for us, it's likely patients are going to choose the insurance because of the value that's provided in that coverage, right? How much it's cost them and what they get out of it. From the provider perspective, the choice is going to be, now that you have that card in hand and you can shop around, where do I go? Do I go to MedStar? Do I go to Unity? Do I go to La Clinica? Do I go to Community of Hope? And no one likes to use the C word, and that's competition. You could choose another word if you'd like, but choice reflects that. And if individuals have a choice in where they can go, it's going to set up a pressure on our side to deliver the best value of care that we can. So while that Mercedes may be pleasant and nice, I can't afford that Mercedes. While that Subaru is great, but it breaks down every 10 miles, that's not value either. So for us, it's incumbent upon us as providers of that delivery healthcare system is to demonstrate transparently what that value is so that people can take that card and say, I want that because that's the best use of my dollars and time and energy. So again, to reiterate, the current system that we have right now is not value-based. For the reasons that were mentioned earlier, we are paying too much and not getting enough out of it, demonstrable results. And I think that that's the challenge for us. And so it's not that we compete, but we should all elevate and allow people to choose quality health care that's affordable to the system across the board.
Ms. Dale?
I always go to the member perspective. I spend a lot of time talking to our members because it's really important that we don't forget them in the conversation. So I'm going to kind of think about this from a member perspective. I've been very pleased with some of the nimble changes that we've made in order to recognize what members need. So we used to talk about people being non-compliant and going to the emergency room because that's where they wanted to go, right? But if you put yourself in the member's shoes, one member who I finally got to stop going to the emergency room, because when I run these high utilizing reports, she came up as going like every month. And what she said was, when I go to the emergency room, she happens to live across from United Medical Center, so she could walk there. So that was her first thing, right? She said, Miss Dale, I can walk to the emergency room. They're going to see me, and they take good care of me. I said, well, what do you mean by that? She said, well, they always do a chest x-ray. She has bad allergies, so she would get, sometimes all the nasal symptoms, but sometimes it would turn into something that would get into her chest. And what she said was, they take good care of me every time. So to her, that meant a medical home. So what I would say is that we have to figure out a way to have health become a relationship. A medical home is a place, but if we don't figure out wherever we are in the spectrum that we make a relationship with those persons that need our help in terms of partnering to get them well, that's where we have not succeeded, I believe, is making that relationship. So when someone gets a card, that should be the beginning of the relationship. They should know every time that we're going to call and check and see how things are going, that when they get a letter, it's actually signed by a real person. It's not just, that form letter. And that when they get there, they're going to be treated with a level of dignity and respect. A lot of times I talk to members and I said, well, you have a primary care doctor. You've only gone to see them once. Why won't you go back? And they said, because I always feel like I'm rushed, so I don't have time to ask questions. And sometimes I feel like when I call to make an appointment, the fact that I'm on Medicaid makes it so that I'm not at the priority. My appointment is going to be further out. Those are the types of things that we have to address to make this system truly accessible. One of the changes that has been great to see across the city is our expansion of hours, right? So now we have evening hours and we have Saturday hours. Those are important changes. We need to continue to figure out what we can do differently. For that mom that has to have a mammogram and has children that she can't find someone to watch, we should be offering care, so that during that appointment, rather than her not get a mammogram, and we already know she's at high risk because she's had an aunt and a sister that had breast cancer, why aren't we offering childcare? I mean, that goes back to the issues of what are those other things that are fairly easy to address. If we know that a family has 2 children with asthma and the mom is rightfully taking the child to the emergency room, but part of it is she's in a really old building and she needs some kind of a filter, or in the winter a humidifier, why aren't we looking at paying for those types of things? So we really have to step back and put ourselves in the members' shoes and understand and provide those necessary supports, which I can tell you from the payer perspective cost a lot less.
Thank you very much. Ms. Tilden, what does Blue Cross Blue Shield need to do differently?
I think we over the past 3 years, as I mentioned, embarked on what we call our patient-centered medical home program, which is actually expanded to what we're now calling a total cost of care initiative, which was just actually described in that I think there was a study that came out yesterday that said the top 1% there's 1% of the population that consumes 21% of the overall cost. And when you recognize and actually can identify those members as the ones that need differential focus and care, that's where not only do you improve the quality of and outcomes of those members, but you actually have an opportunity to save money. So for our commercial population, we've put in place all those things that were really quite obvious to us, especially when you have a conversation with a primary care physician. they're churning through patients. They don't have the kind of support that they need for compliance and follow-up. And we said, look, you know what, join our program, and right off the bat, we're going to give you a 12% increase on your overall fees. In addition to that, we are going to give you a local care coordinator, which is a nurse that reports to you, and a regional care coordinator that will help you identify who those high utilization patients are, multiple chronic condition patients are, and help you develop a care plan with them, be the person that navigates them through the system. And guess what? If after a year you look at your projected cost and you beat your projected cost, we're actually going to gain share with you. So there's incentive for them, not only for the primary care physician to take the time because they're actually compensated for it, but take the time to develop a care plan for this person. They have the support of a licensed nurse practitioner who actually helps them to better manage that population. And again, we're going into our third year. We're not only seeing significant improvements in overall quality outcomes, but we're saving money. We're saving money, and our primary care physicians are actually improving and increasing their overall reimbursement rates. So 2 years ago, as I mentioned, recognizing that providing these kinds of supports really makes a difference in overall outcomes, we said, look, we're making these investments in our partners in the community. We initiated what's called a patient-centered medical home safety net initiative, and we invited organizations from the community to propose to us how we could invest in helping them become more patient-centered, whether it's through improvements in technology, additional staff to serve as patient navigators and nurse navigators, whether it's through their ability to provide home health services, which we know are so critical, particularly when we're talking about discharges from the hospital. Ensure what can we do to keep them out of the hospital, but also how can we ensure that they are compliant with their overall plan. Mm-hmm. And so that we've got that in the market, and again, very, very excited about the notion of extending that to the primary care safety net community. Many of you in this audience are actually participants in it. But it has been tremendously successful. Again, I keep pointing to Unity, but I know that they have had great success. I think 1,900 documented ER diversions in the past year and a half alone. Support in place to do that follow-up and ensure that those patients that need that differential focus actually get it. And our hope is that this is something that will play a role in ensuring that of the system of care allows for more efficiency, so that when you are faced with what will be an increase in the number of members that you see who have a card, you can more efficiently manage and see those folks.
Thank you so much. I'd like to take some questions from the audience. You can raise your hand, and I guess we'll get a microphone to you. Anyone with questions? There's one in the back. Can I ask you to identify yourself?
I don't know if that's safe. No, just kidding. Bob Lowry from PNC Bank Healthcare Division. One question I thought about is all those people that don't have access to internet, et cetera. How are we getting the word all the way down to that last individual that can need the care succinctly?
Why don't you take that one, Mila?
Sure. So we recognize that we have a very diverse population here in the district, and many people are very computer savvy. They don't want to talk to a live person. They never want to see a live person. They just want to go online and do everything themselves. That's great, and that's what dchealthlink.com is for. But we also have a population that likes the in-person help. They like the interaction. They're not as computer savvy. They may not trust computers. They may not even have access to a computer in a very easy fashion. So we have provided approximately $6.4 million in grants to local groups, including community health centers, including this great organization, to be on the ground to help people in person. Or people can call our contact center. We are not open 24/7 as I initially thought we would be, but we do have extended hours, 8 a.m. till midnight, Monday through Saturday. And so all of those folks are available, including licensed insurance brokers, to help people figure out what they're eligible for, what the best health plan options are for them, and actually enroll. So whether a consumer wants in-person help or they never want to see one of us, we have something for everyone.
Thank you so much. Another question from the audience? Yes. We'll give you a microphone, and please identify yourself.
I'm Dr. Connie Webster from the University of the District of Columbia, and I have kind of two questions. My first question, is there any special implication for undocumented immigrants as far as the Affordable Care Act? That's number one. And number two is, I hear you talk about collaborations. My question related to collaborations would be, are there any special collaborations or implications for academic institutions?
Linda Elam, can you tackle the first part of that about the undocumented immigrants?
Sure. As far as, and Mila can speak to this as well, but as far as participation in the exchanges, the undocumented population is precluded from that. Now, in the district, we've had a very good history of serving our undocumented residents through the DC Alliance program. That program persists, but undocumented folks are not eligible for Medicaid participation either. So they don't get subsidies, they don't get Medicaid. Also, I would point out another distinction of the district is that we have a very high Medicaid penetration rate. Medicaid is the largest single insurer in the district. We cover 1 in 3 of the residents here. So another really important collaboration piece is the Medicaid component. And if I could just take this advantage of this opportunity just to say, when it comes to those high-cost individuals where a lot of the action is, a lot of them are our beneficiaries, the Medicaid, Medicare dual eligibles, for example. And here in the district, we, for various reasons, have not expanded managed care to that population. But now there are additional programs under the Affordable Care Act and incentives to do system design, payment reform that we'll be looking at much more closely in Medicaid to have a more efficient system that better serves those very high-cost individuals as well.
And the second question was about academics.
Collaborations with academic institutions.
Dr. Padilla.
Just mention a couple of that Unity is currently undertaking. One is we started in July 1st 2 affiliations with academic institutions. One is we have now family medicine residents at Unity, the first community-based, community health center-based residency program in the district that I'm aware of. And also medical students. We're now partnering with AT Stills in Phoenix and have 10 medical students. We will, at the end of a couple of years, it's obviously a 3-year training program, 30 medical students in place throughout Unity's system. And we will have 18 residents, family medicine residents. So that's one way that we're trying to address not only the workforce, but also the training aspect of having our future providers train in a community-based environment, which historically has not been the case in the American healthcare system. The other is it's important to realize that all these things that we're talking about are going to require data and research. So Unity is beefing up its research capability, but not as a passive player, which unfortunately many FQHCs have been in the position of, but more of an active player and trying to be in the driver's seat of the questions, the research questions. So whether it's patient-centered medical home, delivery system, cost effectiveness, we need that academic partnership, but we need it to change in a little bit of a way that has historically been done, and that is having our community-based organizations be the drivers of those research questions.
Quick question for Dr. Tahir and Mr. Wagner. Your hospitals are now going to be graded on how you do. You've got more pressure to prevent readmissions, to improve your quality of care. There's a lot of extra pressure and work that's going to fall to your employees, and you've got a lot more customers coming into the door, although hopefully not through the ER. What are you saying to your workers about the extra work that they're going to do, about how their jobs will be changed by ACA? And what kind of perspective are you painting for them about patient impact and their own futures?
I think for us, I think the issue for our associates is that the future is going to be one of transformation. It isn't going to be, and it actually ties to the question that was posed about what can the academic institutions do. I think it gets down to trying to see what the future looks like and what are those new skill sets that health professionals are going to need, because it's going to be different from what it has been historically. If you think about whether it's navigators, nurse navigators, or it's people to support patient-centered medical homes, it's a whole new set of skills. And I remember a quote that, or I'll try to paraphrase Bill Gates. He said that we overestimate short-term change and underestimate long-term change. And so one of the things that happens is we don't see the change happen as quickly or as significantly in the short term, and we take our eye off the ball, and we don't know how to transform ourselves. So I'm not sure that it's about everybody having to do more, as you kind of postulated the question, that we are going to be graded on readmissions and we're going to be graded on various things. We should be graded on those things. You know, we should be evaluated. It gets back to the competition question that was posed earlier. We should provide the information that allows consumers to make choices and understand what happens in different care settings and in different organizations. That's what spurs us to improvement. None of us want to wake up and look and see that health grades has put our hospital in a bad spot, or our patient satisfaction, our patient experience scores are low. That should motivate all of us. It should motivate our associates. We want our associates to wake up every day and think about putting the patient first. Pretend that what they're doing is caring for a loved one, a member of their family, a member of a friend's family. I think it spurs all of us to do better, and our healthcare system will transform.
Dr. Tahir?
Well, I think it's a matter of education and, so, to some degree, psychology. If you always thought you worked for a hospital and cared for the patients for that moment of time, for those 3 or 4 days that they were in your hospital, and that's the extent of your relationship, then that is a very limited relationship. In primary care, we know different, because the patient has a longitudinal, long-term relationship with a primary care provider. A lot of this for hospital-based health systems or hospital systems is re-educating the community, the associates, the staff, to understand that we're actually caring for patients throughout their life in a dynamic and ongoing way. And even if your relationship with the patient is for these 3 or 4 days, this patient is ours through either our primary care providers or our partners who are primary care providers in the community. And as a result, you have this role that fits into this larger whole in a more clear and specific way than ever. And what are the clear and specific ways? Well, for example, we didn't always provide home-based care 10 years ago, 20 years ago. We now understand that that's fundamental and organized relationship for how a patient not just gets discharged, but also gets cared for in their home, and how the communication is organized such that the home-based care provider, the primary care provider, and the hospital provider are working with the same set of information. And so I think it's evolving our psychology to understand our role is different than it always has been as staff and associates in a traditional hospital setting, but also, too, to really start to make information transparency real. And if I could just take a moment to articulate what I think that means, I believe that means a provider in their native EMR system should have access to all of the care that their patient received, regardless of where they got that care. That you shouldn't have to log off, go to a portal, go to a different place. The information should come to the provider, and should come to the provider in their home EMR, and without more than one click. And so that's rational and logical. You know, if you're counting clicks, if you're on an EMR, right? So I think that's rational for a primary care provider. How do we make all of the information available in the system available to the primary care provider before they enter the exam room through an exchange that's organized and that they don't have to go to, but the information comes to them? And then it's asking those same rational questions for the other care providers that maybe a smaller subset of our patients need, like home care and long-term care, et cetera. So I think it's a different infrastructure that we start to articulate, and then it's also a very different way to think of ourselves and our role in the delivery of the system of care.
All right, thank you so much. One more question from the audience before we take a break. Yes.
Hello, I'm Nico Smith from Children's Hospital. I work with the mobile health. And my question is to the panel, basically, how do you think that the social work part of healthcare, because someone spoke about treating the whole family, treating not just that couple of days that the patient is in there, and how, if any of you are starting to integrate the social work into the everyday care of that patient.
Ms. Elam?
I would like to just preface that because we don't do care delivery where I am, but before we end, I know I'd feel a failure if we didn't talk about behavioral health and its critical role in all of this, in high-cost care, in people's efficacy around seeking care and so forth. And without addressing that, and I can tell you we've done a lot of deep data dives in our agency to look at who our most vulnerable and highest cost people are, and there is significant overlap between their mental illness primarily, but also their substance use disorders and their physical health as well. So I think as far as the delivery side, whatever kind of interventions there are going out in the community, going out into the home, et cetera, they've got to consider all aspects of the health profile that way.
So I'm so glad you raised that question, and thank you, Linda, for your comment too. So social workers are a really important part of the care team. Nurses are important, but social workers are looking at another sphere that definitely impacts health and health outcomes. And so at AmeriHealth, we have social workers that are part of the team. We are always actively looking at members to understand the context in which they live that's impacting their health. And when we identify certain risks, it's important to have a social worker do that type of assessment and give us guidance around addressing that risk. So a lot of the work our social workers do is around assisting with food stability, housing instability, and resources, because if someone is a newly diagnosed diabetic and needs to change their diet, but there's not a grocery store close by, or they don't have funds to get to the grocery store or go often enough so that they have fresh fruits and vegetables versus canned goods, that doesn't work. And so we often use our social workers to help us with identifying the necessary resources for members. I do want to say one thing about the behavioral health component. That's not completely what our social workers do. We have an integrated team where we have nurses with behavioral health background that work to combine both the medical and the psychological, interventions that are needed. However, we still need to figure out a policy that allows for that sharing of information so that when we're treating someone, we're really looking at the whole person. It's not that we need to share the complete medical record from the psych visit, but there are probably about 3 or 4 essential questions that the care team needs to understand. Is that person receiving medication? Is that person taking the medication? Is the medication affecting their physical condition? And are they in care? Are they coming to their visits, right? So if we could just exchange that limited data set of information with the care team, with the primary care provider, it takes us a great way in terms of really integrating and coordinating and treating the whole person.
Thank you so much. Oh, yes.
If I could just make one
Very quickly,
comment and a little bit of an announcement. One of the things that I think I would be shot if I go back to the office and not mention is the fact that recognizing the importance of access to behavioral health care, on Monday we'll be issuing an RFP for proposals to extend access to behavioral health care through telemedicine. And so we recognize that many of the folks that are dealing with multiple chronic conditions have underlying behavioral health issues that in large part contribute to their health outcomes. And so we're looking forward to, I'm sure many of you here, considering how you can expand access to behavioral health through telemedicine, and you'll see that by visiting Care First's website. I'm sure we'll work with Jackie to post information on how you can apply for those funds, but it'll be a opportunity for up to 3 years of funding. We're looking for innovation, and again, we're looking for proposals that demonstrate that they serve, that you can reach and obviously serve an underserved population. So we look forward to your consideration of that.
Thank you so much. Maria Harris-Tilden, Mila Kaufman, Louis Padilla, Fahad Tahir, Eric Wagner, Karen Dale, and Linda Elam. Let's give them all a round of applause.